So, welcome back to Taking Charge of My Cancer podcast. And I have an amazing guest today who I've been trying to get into doing this with me for a while, but he's a busy man. So, this is Dr. Austin Lam. He's an assistant professor at the University of Florida, Division of Head and Neck Oncology and Microvascular Reconstructive Surgery. He is committed to provide personalized, high quality care from the initial consultation through surgery and follow up visits. He was first drawn to the field when he witnessed the profound dedication of head and neck surgeons. Now, as a specialist in head and neck oncology and microvascular reconstructive surgery, he intends to keep the same dedication to deliver exceptional patient care. From a patient initial consultation to surgery and ongoing surveillance visits, he is devoted to provide the highest quality care and fostering enduring relationships with patients. He prioritized providing clear communication, ensuring that each patient fully understands their condition and is actively involved in the decision-making process. In addition to his clinical practice, he's passionate about education and research. He's actively involved in training the next generation of medical professionals, including medical students, residents, and fellows. His contributions to cutting-edge research are aimed at advance the field of improving patient outcomes. Outside his professional life, he enjoys spending time outdoors with his family and dog, and he's an avid hiker and skier and have been keen interest in college football. So thank you again, Dr. Lam, for being here with me today.
Yeah, thank you so much for having me.
Great. So you want to share your journey into head and neck surgery and what drew you to oncology specifically?
I graduated from medical school from Emory University in Atlanta, and then I went on to residency at the University of Washington in Seattle. During residency, we spent a little bit of time in all the different subspecialties within otolaryngology. Facial plastic surgery, otology, laryngology, rhinology, pediatric otolaryngology, as well as head and neck surgery. And as you mentioned in the intro there, I was really drawn to the commitment to patients and working with them through these really difficult times that is a cancer diagnosis.
Mhm.
Some of the fields within medicine are a bit more transactional, whereas head and neck oncology, you really develop strong relationships with your patients that are long lasting. I follow patients from their initial diagnosis up to 5, 10 years, and sometimes even longer afterwards. And I think that was what really drew me to this field.
Mhm. It is really nice. And again, patients love you, by the way. You've been just amazing. Some cases that is like, how in the world, you guys amaze me. Like we have a common patient right now that literally, his face did not look great. And then all of a sudden after surgery, 2 weeks later is doing amazing. So talking and functional and happy. And besides all these major surgery you guys do. So I have the privilege to shadow one of you in the past when I was learning oncology to see exactly um, what was a neck dissection look like, what a glossectomy looks like, what a free flap looks like. And wow, 12 hours there shadowing you guys, which is like amazed me again. This patient I see 2 weeks later and they're talking and they're moving their arms and they after all that I saw. So amazing the work that you guys do. So I really appreciate that. What type of cancer fall under head and neck cancer and how common they are?
Head and neck cancer. Generally speaking, head and neck cancers are cancers of the upper aerodigestive tract, though we also treat skin cancers of the head and neck. We treat thyroid cancers, we treat parathyroid cancers. For the most part, any cancer that falls within the head and neck that's outside of the brain, we'll treat it. But when people refer to head and neck cancers, usually they're talking about mucosal cancer. Squamous cell carcinoma is by far the most common one. About 95% of all cancers of the head and neck are squamous cell carcinoma. About 50,000 or so new cases every year within the United States.
Wow. What do you think that was trigger that?
What triggered
The high amount of squamous cell carcinoma have.
So there's a few things, there's the traditional risk factors like smoking and drinking. Those are the major risk factors for most cancers of the head and neck. Though for some cancers like throat cancer, we're actually seeing HPV become more common than the kind of traditional smoking related throat cancer. But for oral cavity, larynx, those still smoking and drinking are the biggest risk factors.
Okay. How do you typically approach diagnose and staging in these cases? So for
That's a People present in many different ways. They may come to us with a neck mass, they may come to us with pain, they may come to us with a tongue or a throat mass. Typically, the diagnostic workup includes imaging and a biopsy. When patients come to me, they've usually been referred to me for a reason. Maybe that some cancer is suspected, and so in my clinic, I'll often do a biopsy and order imaging, and that will lead us down the path of diagnosis.
Okay. And could you walk the audience through a typical treatment plan and the role that surgery plays alongside radiation and chemotherapy?
Yeah, so all three of those things you mentioned are mainstays of treatment for cancers of the head and neck. Typically, they'll come to me, we'll form a diagnosis, or they'll come to me with a diagnosis.
Mhm.
We'll have to do the complete staging workup, so that will typically include, as I mentioned, some imaging. So the most common one is a CAT scan of the head and neck, as well as a CAT scan of the lungs. So we need to see how advanced the cancer is and what sorts of structures the cancer involves, as well as we know whether or not it has spread to the lymph nodes, and all those things will affect the treatment plan. Typically, after the staging workup, I'll present their case at our head and neck tumor board meeting. Oftentimes, during their clinic visit, I'd say usually during their clinic visit, I have a pretty good idea of what the recommendation is going to be out of that head and neck tumor board. And so I'll discuss that with them. But then at the tumor board meeting, we meet with the other head and neck surgeons, such as myself. We meet with radiation oncologists, medical oncologists, the radiologists, pathologists, as well as therapists like yourself are often there in the room, and we all formulate a really comprehensive treatment plan for those patients. As for what that treatment includes, it really depends on the location, like I said, the structures that are involved and the stage of the cancer. For most cancers of the head and neck, surgery is really the mainstay if the patient is a good candidate for surgery.
Okay.
They are a good candidate for surgery. That's often the first stage of treatment. And then depending again on the stage and some of the possible um, negative prognostic indicators that may be on their pathology, they may get chemotherapy and radiation afterwards.
Okay. Have you experienced any patients that get radiation first before surgery as a first hand of it?
Absolutely. So I mentioned for most cancers, but there's many cancers in the head and neck that radiation is the best first treatment option. So one is like early stage laryngeal cancers, so cancers of the voice box, for example.
Okay.
Surgery in some of those cases, would involve a total laryngectomy or removing the entire voice box, and that's that has huge communication and lifestyle changes to that patient, and so radiation is typically the first line treatment for some of those earlier stage laryngeal cancers, as well as many maybe more advanced cancers of the oral pharynx or the tonsils. Um, some early stage tonsil cancers are very well treated with surgery, but the more advanced ones would involve a more a bigger surgery that would have more functional limit or that would result in more functional limitations,
Mhm.
and would often require radiation afterwards. The outcome is going to be the same if they get radiation beforehand, because many of those respond very well to radiation. Then radiation is going to be a better first line treatment for them. So absolutely, we do treat patients with radiation first all the time.
Okay, perfect. Have you noticed? I understand like a lot of the P16 positive or pharyngeal that gets treated just with radiation chemo look like has been a good outcomes with that. But have you ever seen any like I know the chemo doses are pretty small. Have you seen any kind of like neuropathy or any complications from chemotherapy on these patients at all?
All the time.
Oh,
Yep.
really?
Yeah,
Okay.
unfortunately, no treatment we have is totally benign. I'd say neuropathies maybe not quite as common, but the more common thing that I see from some of the chemotherapies that patients get are like mucositis.
Oh,
Um, those are not usually as long lasting, but we do see those side effects all the time.
okay. And you think that is more because not necessarily radiation, but is the combination with the chemotherapy that get them more susceptible to it?
That's hard to say. It's hard
Okay.
to say. So
Okay.
they definitely have a like a synergistic effect on one another.
Okay.
Um, I can't think of many, throat cancers that we would treat with chemotherapy alone unless we're doing what we call neoadjuvant chemotherapy.
Mhm.
And those are usually for much, much more advanced cases. And so hard to say which one is really having that effect, but we definitely see those effects in patients when they get those treatments.
Got you. How do you balance removing cancer effectively while preserving essential functions like speech, swallowing, and appearance, right? Because this is what I know you guys struggle all the time with. What I hear, we have some great tumor boards where it's like everybody has really good outcomes, and we have some very sad days where it's like, God, give us some, like everybody's so advanced, and I'm sure you're struggling, like, do we save your life? But what are we gonna leave you with, right? So how do you manage that?
Absolutely. That's the constant struggle, the thing that we have to. So I think the best way to management is really by managing patient expectations. And so there are many cancers that I see where I will tell the patients that, hey, I think you're going to do really well with this surgery. Like, yes, initially you'll have some, some difficulties. It's going to take some practice, but you're going to do really well. And I think in a few months, people won't even really be able to tell that you had a surgery. But then there are other ones where I tell them, look, we need to cure you of this cancer, and curing you of this cancer is going to, really change the way that, you live. I'd say the most common one there would be like a laryngeal cancer where I'm doing a total laryngectomy. Many patients will do extremely well after that surgery, and I've seen patients who you can actually barely tell that they've had the surgery. Their voice is still really good. We have things that we can do to actually allow them to speak afterwards, but that's not everybody.
Mhm.
There's some patients that I know are going to struggle more, and so counseling them and really preparing them for those lifestyle changes is for me the best way that I can help them to manage to manage that.
Okay, got you. How important is collaboration with other specialists like oncologists, speech therapists, physical therapists, nutritionists, and your treatment approach?
It's critical. I think it's one of the things that makes receiving your care at a cancer center really important because we have all of those specialists. Um, if I were to treat a patient by myself, the chances of them doing well is going to be much, much, much lower. So I meet with all of those specialists that you mentioned. We talk all the time, and they're an integral part of the treatment team. The radiation oncologist and the medical oncologist, especially for getting them through the cancer treatment, but then the physical therapist, the occupational therapist, and speech therapist for getting them back to their sorry about that, back to their functional um, baseline.
Okay. Have you noticed a difference so one thing that I think I mentioned that to you before you came on board with us, and before COVID show up, we used to really kind of try to see a lot of the patients pre-op, kind of help them to realize what was coming down the road, right? Mainly when we talk about neck dissections and a risk for spinal accessory nerve injury and lymphedema, and even some of these mandibulectomies, right? Like, their jaw mobility and so forth. And we really had really great outcomes because the patients kind of like realized that. And then we have some kind of baseline measures, right? So we were able to look back after work and say, yeah, well, your shoulder was kind of moving that way before. So this is not really spinal accessory nerve. You have that issue before. Look at the video that we did on you. Or even just taking pictures or take measurements of their face, right? Because sometimes it's like, if we see them pose up, how do I know what you look like prior to surgery? You have a picture. Have you noticed anything? So we just go based on subjective versus objective data. Have you noticed a difference with that? Like when we see patients pre versus not seeing them pre-op?
Yeah, absolutely. And I think a lot of it comes back to that managing expectations.
Mhm.
Um, I definitely think that it makes a difference. I think there are challenges that come with it because there are a lot of visits that these patients have. But no, I absolutely agree that the outcomes are overall better when they've, been counseled on these things, when they've started their therapies beforehand. Strength is something that they go through these huge surgeries or in the hospital for a long time. They lose a lot of strength.
Yeah.
And if they get started on exercises beforehand, whether it's with you guys or speech therapy, I think they're really extremely helpful.
Okay, great. Right. But thank you for doing that and try to bring that back again.
Yeah, of course, of
A little
course.
struggles with that,
Yep.
different physicians approach. So we appreciate that.
Yeah.
What are the biggest challenges your patients face emotionally and functionally, and how do you support them?
So, yeah, so emotionally, depression is very common with all cancer diagnoses, and so depression is extremely common. It's a tough thing because they're going through a lot. They're, after surgery, they're getting radiation and chemotherapy. They're going every day for those for 6 weeks, and so it's hard for them to find, time to do anything else but get treatment. We're working on survivorship programs, which I think, help with that as well. But working closely with our colleagues like you guys, but also the psychiatry, rehab, psychology, those are really helpful for those patients. Functionally, it really depends a lot on the surgery that they've had. But again, getting them involved with the different, therapies, and getting them practicing. One thing that I like to do is get them, so I guess, mobilizing really early, like the next day after surgery. I want them walking around as much as they can. When they're sitting in bed, they lose a lot of their strength, and I find that they don't heal as well. So I like them not just to be in a chair, but actually walking around right after surgery. For most of my patients with, pharyngeal cancers, I try to get them eating as quickly as possible. So the day after surgery, I have them drinking liquids. I don't necessarily want them eating foods that quickly afterwards, but I get them drinking liquids as quickly as possible, which I think helps them to recover those functions more quickly as well.
Do you have any like again, because I don't work in acute care, so I'm not too sure what's going on in there. But with your free flaps, are those are you more like cautious about motion for their neck while they're on the ICU for a certain amount of time?
Yeah, it depends a little bit on the patient. One of the things with the neck mobility is if we're doing a free flap surgery, we attach the vessels that come from that flap to vessels in their neck, and usually I don't want them turning their neck to the side that we've hooked up the vessels on because it can kink the vein.
Okay.
And so we do counsel them, to try to avoid turning their neck, one way or the other. I think it's actually pretty rare that that's a major issue unless they're sleeping with their head turned that way. But if they just turn their head briefly, I don't find it, I don't believe at least that that's a
Okay.
huge issue. But yeah, at least for the first like 3 or 4, maybe a week after surgery, we don't want them turning their head too much to one way. But otherwise, for the most part, I want them doing as much as they can, at least normal day-to-day activities as much as they can.
Okay, perfect, perfect. So yeah, by the time we see them, it's usually, we see them like 2 weeks or later. So at that point, they won't have any restrictions with that in particular.
Correct.
Okay,
Correct.
perfect.
Yeah, at that point, for the most part, they've had new blood vessels grow in, so they shouldn't really even be reliable on that pedicle.
Okay, perfect. How about for your like fibulectomies? Just keep them on the walking booth. Do you keep them usually 4 weeks, or 6 weeks? What are your thoughts on that?
For the walking boot,
Uh-huh.
yeah, I've gone back and forth with that a little bit. I think for me, the main thing that I don't want them to develop foot drops. So I actually like for them to wear the bed more when they're like laying in bed, so it's just not
Okay.
sitting down.
Okay.
Um, Walking around more, and I'd say, there are I've seen and heard many different theories on how to approach the boot. When they're walking around, I don't actually mind as much if they take that boot off unless they're having issues with pain.
Okay.
Usually, I have them wear it for a week or two.
Okay, good. So it's shorter. Okay. Okay, good. It's funny how, again, a lot of different thoughts, a lot of different surgeons, a lot of different, it's like, okay, which one it is? Who? So you're with Dr. Lam, it's only 2 weeks. Are you with this person? Is like how many weeks? So sometimes it's like hard to like, okay, what do we do depending on each one of you, right? Some of you guys tend to be more conservative. Some of you guys are like, no, let's just get moving and going. So good
Yep.
for me to know that. Same thing with the splints for the hand when it's radius.
So that one I have them wear actually for a little bit longer. Not really, because I don't want them moving their wrists for wrist mobility, but more because we're putting on a skin graft there. So
Okay.
the same thing with the leg. I like the leg to be wrapped for a bit longer.
Okay.
The forearm, the splint is actually more to keep that skin graft attached to the underlying tissue because
Okay.
we want that skin graft to take.
So how long do you like those for? Like 4 weeks?
Yeah, about that.
Okay.
Hmm.
Okay. Perfect. That's good clarification. Um, are any emerging treatments or technologies in head and neck oncology that you're particularly excited about?
Yeah, so one big emerging treatment, you've probably seen us talk about this a lot at Tumor Board, is immunotherapy. So immunotherapies aren't perfect, but they're really kind of the new, really the big show in town as far as new treatments for head and neck cancers. They're kind of more directed approaches to these cancer or to systemic treatments. They use the body's own immune system to attack the cancer, and in some people they work extremely well. They're generally speaking, they're still not first line treatments, but for patients in whom, surgery is not a good option or they, have already had chemo and radiation,
Okay.
they represent a really, really, really good alternative.
So this is more for those type of patients more than somebody who is recently diagnosed and is a
Yeah.
possibility of surgery. We're still going surgery first then
Yep.
more radiation and possibility to add the immunotherapy to it.
Yep. For right now, this they're still relatively new, especially in the head and neck cancer realm. They've only been around for, a few years now. I think as we get more data and more therapies, so there are several immunotherapies that we're using, but there's more and more coming out all the time. As we get more and more of those, I think we'll see them being used, as like first line treatments potentially in the future. You may have heard, there are some instances where um, especially for some of the skin cancers, we're starting to use them as first line because we know that the surgery is going to be a bit morbid. Even though the patient is a candidate for surgery, I'll say, hey, maybe we can try this immunotherapy and see if we can potentially avoid that big surgery by shrinking that tumor way down. And some people respond extremely well. Some don't, and they end up getting that surgery that they would have gotten anyways. But in some patients, we're able to avoid it completely.
Oh, wow, completely. Not even taking any lesion afterward. Oh,
Yeah.
wow.
It's all still sort of not the standard, but there are some where the tumor goes away completely and we keep them on that immunotherapy either for a year or in some cases even indefinitely.
Oh, wow. That's very interesting. Are you guys managing any melanomas or that's something, even
Yep.
if it's on the face, then you will. Okay.
Yeah, the head and neck. Yeah, we'll manage those often.
Okay. Okay. So some as well, great. I know that in the past they used to treat them with that, right? Some of the immunotherapy with the melanomas.
Yep, yep. So we still are. Usually we'll still do surgery and the immunotherapy will be an adjuvant treatment.
Okay, got you. Excited. What about will you give someone, what advice will you give someone newly diagnosed with head and neck cancer, and how can patients advocate for themselves and ensure that they're getting comprehensive care?
Yeah, so I think, the advice that I would give them is just keep pushing. It's going to be a difficult time as you go through this treatment, but most people get through it and they do very, very well. You may have some side effects for a while afterwards, and some people will be living with those for the rest of their lives, but most people do extremely well, even despite those side effects. So I'd say that's the biggest piece of advice. Just keep pushing, keep pushing, work with your support system and get through it. The second part of your question was, can you repeat the second part?
Yeah, how can patients advocate for themselves and ensure that they're getting comprehensive care?
Yeah, so if you go onto the NCI website, the National Cancer Institute, you'll see a list of cancer centers and cancer institutes on there. And I think for head and neck cancers, especially more advanced ones, it's extremely important. Even not as advanced cancers, extremely important to be treated at one of those centers. The outcomes tend to be better, and you'll get the comprehensive care that we've talked about throughout this interview.
Okay, that's very good. And then if they can, and they can come, like you guys have patients from all over the place, right? So people comes from far away and then I know we're really good about try to get all the appointments scheduled on the same day or as much as we can. So it's less burden for them, but they can always reach us to us, right?
Absolutely. Yeah, we get patients from the entire state of Florida, Georgia, Alabama. So yeah, you can definitely be treated here.
Okay, perfect. What keeps you inspired in this demanding field?
It's my patients. I really become attached to the patients. They're fantastic people. And just, working with them, getting them through these difficult times, that's what keeps me going.
That's so great. Well, is anything else that you would like to add before I let you go, Dr. Lam?
No, I just want to thank you for having me on. It's been a lot of fun. I look forward to seeing this once it comes out.
Okay, excellent. Very good. Thank you so much. I really appreciate. I think that you are giving a lot of nice help and information to the audience out there listening to this. And so I really appreciate your time.
Of course, thank you.
All right. Have a great rest of the afternoon.
You too. Take care.
Okay, bye.